Hello and welcome back to Smart Lawyers, Love, Dumb Nurses, the podcast where I talk about what actually matters in healthcare, not what sounds good in a boardroom. I'm your host, Dr. Brian Smith, and today I'm diving into something that's been my professional passion for decades, hospice and palliative care. If you're a nurse, a student nurse, a clinician in any capacity, or if you're a patient or family member navigating the end-of-life journey, this episode is for you. After 40 years in nursing, 25 of those as a nurse educator, and 10 years as a hospice case manager, I've learned that hospice isn't about giving up. It's about giving everything. Let's start with a little history, because understanding where we've been helps us understand why we do what we do today. When we talk about the modern hospice, we need to tip our hats to Dame Cicely Saunders, a former nurse who founded St. Christopher's Hospice in London, 1967. Before that, dying was something we warehoused, literally and figuratively. Saunders had a radical idea. What if we could provide comfort and dignity for people at the end of their lives? What if dying could be treated as a clinical specialty, not a failure to cure? That concept shifted everything. In the 1970s, hospice started taking root in the United States, but honestly, it was slow going. People were uncomfortable with death. Doctors were trained to fight it. And nurses? Well, they were caught in the middle, trying to provide compassionate care while working within a system that still viewed the dying as a loss of revenue, not a success in management. Fast forward to today, hospice has evolved dramatically. We've moved from inpatient-focused care to predominantly home-based models. We've integrated palliative care principles into earlier stages of serious illness, not just at the very end. And the medication science. We now have options that would have seemed miraculous 30 years ago. But here's what hasn't changed, and what never should. The fundamental principle that hospice is about quality of life, not quantity of days. That distinction matters more than anything else I'll talk about today. Let me be blunt. Untreated pain in hospice is malpractice. Full stop. I've seen it. I've fought against it. And I've watched it unnecessarily steal dignity from people in their final days. So let's talk about pain management with the seriousness it deserves. Pain in hospice isn't just physical, though that's where we start. It's also emotional pain, spiritual pain, and existential pain. As nurses, we address all of it. However, managing physical pain is where we build the foundation for everything else. The key concept most people get wrong is this. Breakthrough pain is not an afterthought. It's central to your pain management strategy. Breakthrough pain occurs despite baseline pain medications. It's that sudden spike that breaks through your patient's coverage. If you're not proactively managing it, you're setting your patient up for unnecessary suffering. And here's what I tell nurses. Treat pain like an iceberg. You see the surface, your patient's baseline pain, but breakthrough pain is that massive portion underneath that can sink the ship if you're not paying attention. Let's talk about pharmacology. And I promise this won't be a pharmacy lecture, because good nursing is about understanding medication, not just memorizing it. Opioids. That's the gold standard for moderate to severe pain in hospice. Why? Because they work, and they work quickly in many cases. We typically use morphine, the classic, reliable, predictable, flexible in its routes of administration. Start low, titrate slowly, watch for side effects. Hydromorphone, more potent than morphine, and some patients tolerate it better. It's great when you need stronger pain control in a smaller volume. Fentanyl. This transdermal patch is a game changer for stable chronic pain, though the transmucosal forms are excellent for breakthrough pain. Methadone. Don't underestimate this one. It has a long half-life and can be incredibly effective for neuropathic pain when managed carefully. But here's what separates good nurses from exceptional nurses. Understanding that opioids work better when combined with other analgesics. We call this multimodal pain management, and it's not fancy jargon, it's smart medicine. Non-opioid adjuvants amplify pain control. NSAIDs for inflammatory pain, though careful with renal function and GI concerns in the dying. Acetaminophen, still useful, particularly for baseline pain. Gabapentin and pregabalin. These are crucial for neuropathic pain. A patient burning from neuropathy won't get relief from opioids alone, but add a gabapentin and suddenly they're comfortable. Corticosteroids. Short-term use in hospice can reduce inflammation and provide a palliative boost. And then there's local anesthetics, creams, patches, and injections that target pain at the source. Sometimes the smartest thing you can do is prevent pain from transmitting in the first place. But when we talk about meds, we have to acknowledge something else: nausea. Nausea in hospice is often multifactorial. Your patient might feel sick from pain, from medications, from constipation, from anxiety, or from the disease itself. As nurses, we have to think layers. And yes, we have medications. Ondansetron, Zofran, fast-acting, works well for chemo-related or medication-induced nausea. The sublingual dissolving tablets are perfect when swallowing is difficult. Metoclopramide, Reglan, enhances gastric motility. It helps when nausea is tied to delayed gastric emptying. Use cautiously in the dying, as tardive dyskinesia is a real concern with long-term use. Prochlorperazine, Compazine, the classic antihistamine. Suppositories are a game changer when oral meds aren't feasible. Haloperidol, sometimes called the hospice secret weapon. It's antipsychotic, antiemetic, and works for nausea in lower doses that doesn't respond to other agents. Promethazine, sedating, but that's sometimes a benefit. Excellent when nausea is accompanied by anxiety. Scopolamine, particularly useful for nausea related to increased secretions and bowel obstruction. But here's the intelligence piece. If your patient is nauseated because they're severely constipated from opioids, giving them stronger antiemetics without addressing the constipation is like mopping up water without turning off the faucet. And here's something I've observed over 4 decades. Respiratory distress, shortness of breath, and anxiety often mistaken for three separate problems when they're really one problem wearing three masks. Imagine this. Your patient has advanced heart failure. They become short of breath, which triggers anxiety, which makes them tense and shallow breathe more, which worsens their oxygen levels. Now they're panicking. Is the primary problem respiratory or psychological? Yes. As smart nurses, we address this interconnection head on. The medications for respiratory support and anxiety include low-dose morphine or hydromorphone. This is the elegant solution many nurses miss. Opioids don't just treat pain. They reduce the respiratory drive sensation and anxiety simultaneously. A patient in acute respiratory distress often gets instant relief from IV morphine because it addresses the terrifying feeling of not being able to breathe. Benzodiazepines, such as lorazepam and midazolam, essential for anxiety and end-of-life care. They also reduce respiratory drive and provide sedation. Midazolam is particularly valuable because it can be given IV, IM, or sublingual. Flexibility that matters when routes change. Oxygen. Maybe you've heard of it. We still use it, but judiciously. Sometimes oxygen improves comfort. Sometimes it doesn't. The goal is comfort, not lab values in hospice. Fan therapy. Don't laugh. The sensation of air movement on the face can profoundly reduce the sensation of dyspnea. Low tech sometimes beats high tech. And the deeper lesson, when you see respiratory distress, your patient isn't trying to breathe harder because their lungs are failing. They're doing it because their brain is screaming that they're suffocating. A small dose of opioid calms that signal. It impacts their respiratory mechanics. Opioids save lives in hospice, but they have a dark side, constipation. And I mean constipation so severe it can actually contribute to nausea, pain, and reduced quality of life. I've seen it many times. It's not just an inconvenience, it's a clinical issue that demands proactive management from day one. This is where excellent hospice nursing shows itself. Not waiting for constipation to happen, but preventing it. Which brings us to bowel management medications. Docusate, Colace. This is a stool softener, not a laxative. It allows water to mix into stool. It's preventative and essential when starting opioids. Senna, a stimulant laxative that actually increases bowel motility. It's old, it's reliable, and combined with Docusate, it's often your first line. Bisocatal, similar to Senna, but sometimes more potent. In the old days, we called them yellow bombers. They're great when Senna isn't quite enough. Lactulose, osmotic laxatives that pull water into the bowel. Polyethylene glycol. This is often better tolerated than lactulose because it doesn't cause gas and bloating in the same way. Methylnaltrexone. This is your advanced tool. It's a receptor antagonist that reverses opioid-induced constipation without affecting pain control. It is expensive, but when a patient is impacted and traditional measures aren't working, it's transformative. And here's the pearl. Suppositories and enemas aren't just rescue measures. They're part of your preventive strategy. A simple glycerin suppository every other day might prevent the full-blown impaction that requires digital disimpaction. And if you've ever performed digital disimpaction on a dying patient, you know why prevention is infinitely superior to rescue. The bloating and abdominal discomfort from constipation also worsens nausea. So managing bowel function reduces your nausea medication needs. It's all connected. I want to talk about routes of medication. This is the overlooked game changer. And this is where hospice nursing becomes an art form, because when your patient can't swallow, can't tolerate food, or has a compromised GI tract, oral medications become useless. And that's when intelligent nurses pivot. Here are the routes that changed everything in hospice. Sublingual, under the tongue, where mucosa absorption is rapid. This is brilliant for breakthrough pain, anxiety, and nausea. Morphine, hydromorphone, lorazepam, and ondansetron, all common forms that dissolve sublingually. Patient swallowing is difficult? No problem. Slip a tablet under the tongue, and within minutes you have systemic absorption. Subcutaneous. Here's where hospice nurses become medication artists. Subcutaneous infusions are steady, reliable, and provide continuous medication delivery when oral routes fail. A butterfly needle in the chest wall or arm, connected to a small syringe driver, and suddenly you can deliver morphine, lorazepam, metoclopramide, haloperidol, and even scopolamine continuously. Many families, trained by a skilled nurse, can even manage these at home. I've watched families find profound relief when we transition to subcutaneous therapy. They're no longer struggling to get pills down a patient's throat. The patient isn't choking or aspirating. Pain is controlled consistently. It's almost like watching fog lift. The rectal route. Yes, we have to talk about it. Suppositories and enemas aren't just for constipation management. They're legitimate medication routes. Morphine suppositories, Bisocodyl suppositories, and anti-anxiety medications can all be administered rectally. Is it less glamorous? Sure. Is it effective? Absolutely. Transdermal. Fentanyl patches represent one of the biggest advances in hospice care. They're steady, predictable medication delivery without daily pills. We typically start with the 12 to 25 microgram patch and titrate based on breakthrough pain meds. IV and IM. They're still essential, particularly in inpatient hospice settings or when rapid medication delivery is needed. And then there's the PICC line and the port. These are the breakthrough nobody talks about enough. I have found in hospice that implanted ports have transformed late-stage cancer care and complex hospice situations. A patient with a port in place can receive IV medications, fluids for comfort, and even blood products if indicated, all without repeated needle sticks. The port is accessed via a special needle. It's durable, and it removes the trauma of repeatedly trying to find a suitable vein in a compromised patient. For nurses managing hospice patients at home or in facilities, recognizing when a port is present and knowing how to access it safely is essential. It's a technical skill that expands your medication options dramatically. So, we've talked about medications. Now let's talk about what makes hospice nurses irreplaceable. In my 40 years of nursing, I've come to understand that medication is maybe 50% of hospice care. The other 50%, it's your presence. It's your expertise. It's your ability to read a room, recognize suffering before your patient can articulate it, and respond with both science and compassion. Hospice nurses aren't just medication administrators. You are also a detective, a counselor, a translator between the medical world and the human experience. When a patient says, "I feel uncomfortable," a regular nurse might adjust the blanket. A hospice nurse asks 14 follow-up questions. Is it physical pain, nausea, anxiety, spiritual distress, fear of dying, of being a burden? Expertise matters. You understand opioid management at a level most nurses never touch. You know the difference between pursed lip breathing and panic. You recognize the subtle signs of increased secretions that signal the final days. You manage ports and subcutaneous infusions with confidence. And let's honor the entire team, because no hospice nurse works alone. Social workers, physicians, chaplains, aides. But the nurse is often the touchstone. You're the one in the home. You're the one the family calls at 11 p.m. when pain breaks through. You're the one who notices that the patient hasn't eaten in 3 days, which means dehydration is intensifying their confusion, which means we need to adjust our medications. I spent 10 years as a hospice case manager, and I saw firsthand how the best outcomes come from the best nurses, the ones who communicated clearly with the interdisciplinary team, the ones who advocated fiercely for their patients, the ones who didn't just follow protocols. They thought critically about how to apply them to the unique human being in front of them. One of the biggest myths in healthcare is that communication is a soft skill. That's nonsense. In hospice, communication is clinical care. Over my years as a case manager and an educator, I developed a communication framework I still use. Clarity first. Don't hide behind the medical jargon. A family member doesn't need to understand the pathophysiology of respiratory compromise. They need to understand your mother is struggling to breathe, and we're going to give her medication that will make her feel less panicked and more comfortable. Always honesty. If pain is going to be difficult to manage, say so. If death is hours or days away, say so. If you don't know something, say so. Do more listening than talking. The best communication in hospice isn't about what you say, it's about what you hear. What are the family's fears? What does the patient still want to accomplish? What gives them meaning? Meeting people where they are. Some families need detailed medication explanations. Others need reassurance. Some patients want to talk about dying. Others want to talk about their grandkids. Your job as a hospice nurse or hospice staff member is to recognize the difference and adapt. And here's a reality check. Our population is aging. People are living longer with complex chronic illnesses. The demand for hospice and palliative care nurses has never been higher, and it's only going to grow. In my 10 years as a case manager, I watched hospice transition from something done in hospital settings to something done primarily in homes. That shift increased the autonomy required of nurses dramatically. You're not just executing orders, you're problem solving independently, managing complex medication regimens, and serving as the clinical eyes and ears for the entire team. The skills I developed as a hospice case manager blood draws, IV therapy, central line management, subcutaneous infusion setup, port access, complex medication management. Those aren't specialty skills anymore. They're increasingly baseline expectations for hospice nurses. And honestly, I think that's appropriate. Our patients deserve expertise. Our families deserve competence. Our profession, and yes, this is a profession, demands it. And let me share a few observations from 4 decades in this profession. The family's trauma is sometimes bigger than the patient's. A daughter watching her mother die will remember whether you were kind more than whether her pain was perfectly controlled. Both matter, but don't lose sight of the human element while managing the clinical element. Constipation prevention saves families from guilt. I can't tell you how many family members blamed themselves for pain management problems that really stemmed from preventable constipation. Subcutaneous therapy is underprescribed. Nurses often accept, well, we can't give that medication, when really there's a route that would work beautifully. Advocate. Ask about subcutaneous options. Ask about sublingual forms. Your creativity in medication routes directly impacts patient comfort. And remember that the last days are a privilege, not a burden. If you're a nurse who groans when you're assigned a dying patient, maybe reassess your career, because being with someone at the threshold of life's greatest transition is sacred work. That privilege should humble you. And remember, you're going to lose patience, and it should matter. If it stops mattering, it's time to leave hospice work. The fact that these relationships end in death doesn't make them less meaningful. It makes them more so. So, in closing, 40 years in nursing has taught me that the systems around us will fail patients in 1,000 ways. The insurance won't approve the medication. The family will be in denial. The physician won't increase the morphine dose as aggressively as needed. But what won't fail? A competent, compassionate nurse who knows that his or her job is to advocate, educate, comfort, and manage symptoms with both science and soul. Hospice nursing isn't for everyone. It requires you to be clinically sharp and emotionally present simultaneously. It requires you to hold hope while accepting reality. It requires you to push boundaries when protocols are inadequate. But if you're smart enough, brave enough, and compassionate enough to do this work, your patients and their families will always remember you. Not as a nurse they once had, but as the person who made their hardest days bearable. Take care of yourselves, take care of your patients, and remember, being a smart nurse in hospice means being willing to think critically, question routinely, and always prioritize the person in front of you over the protocol on the clipboard. Till next time, stay focused, stay prepared, stay kind, and stay tuned. And keep making a difference in the lives of people when it matters most. This has been Smart Lawyers Love Dumb Nurses. My name is Brian Smith.